Yes, now I can start,
Oh,
doctor.
okay.
We're already
Okay.
late. Yeah.
Good evening. I'm Dr. Thomas Anthony. I'm one of the doctors here. Can you confirm your name and age?
Yes, doctor. I am Ramesh. I'm 45 years.
Okay. Mr. Ramesh, how may I call you?
You can call me Ramesh.
Okay. How are you doing today?
I'm doing okay, doctor.
Okay. Ramesh, I hear that you're having problem with your urine. Can I ask in detail about it? And I may examine you later if.
Yes, doctor. You can, doctor.
Okay. So, can you tell me a little bit more about your problem?
Yes, doctor. I've been noticing that my urine is not how it used to be. Like, gradually it is like, now I'm just going only for drops. Few drops is only coming, doctor.
Okay. I'm so sorry to hear. Since when you are having this problem?
Doctor, I've been having this problem for quite a while from now.
Uh, Maybe a week or months or in years?
Doctor, I would say for a couple of weeks, it's just
Okay.
gradually declined and, now it's worse.
Okay. So, did you have any episode of fever, anything at that time?
No, doctor.
Okay. Have you noticed any blood in your urine?
What, doctor?
Any blood in your urine?
There is no blood in my urine, doctor.
Okay. Do you have any pain while passing urine?
No, I don't have any pain, doctor.
Okay. Do you feel like passing and you're not able to pass, or
Doctor, I,
urine is
doctor, I am passing urine, but the
uh,
problem is the urine that is coming is of low amount. It's not of
okay?
how it used to come.
Okay. Do you feel like the urine is inadequately passed?
No, doctor, nothing like that.
Okay. So, um, have you noticed any change in color of the urine?
No, doctor, it is just white in color, doctor.
Okay, okay. So, are you drinking enough fluids?
Yes, I am drinking enough fluids, doctor.
Okay. Did you have any episodes of any vomiting, any loose motion, or anything like that?
No, doctor, not at all. I never had any vomiting nor I had any loose stools.
Okay. So, do you have any tummy pain?
No, doctor, I don't.
Okay. Have you noticed any passing of any gravel or stone through your urine?
No, doctor. Why would they come out? No.
Okay. So, do you have any headache?
No, doctor.
Okay. Do you have any giddiness?
What? Giddy?
Giddiness, giddin. Okay. Do you have any vision problem?
No, doctor.
Any hearing problems?
No, doctor.
Okay. Do you have any difficulty with swallowing?
No, doctor.
Any sores in your mouth?
No, doctor.
Okay.
I mean to
Have
say
you noticed?
in my mouth. There is some source, doctor. In corner of mouth, I do get some source.
Okay. Okay. From how long have you noticed this?
This is going on, I think, maybe for a few months.
Okay. Okay. Have you noticed any tightening of your skin?
I don't know, doctor. Maybe some in my hands.
Okay. Okay. Do you have any difficulty in swallowing?
No, doctor. Not it.
Okay, fine. Have you have any problem, any chest discomfort, any chest pain,
No, doctor.
any racing or pacing of the heart,
No, doctor.
any breathing difficulty,
No, doctor.
no cough?
No, I didn't notice, doctor.
Okay, fine. So, have you noticed any pain, joint pain, or any rashes anywhere in the body?
Doctor, I have some joint pain, doctor. Some
Okay.
joint pain here.
Oh,
Joint pain.
okay. Which all joints, if I may ask?
Yes, doctor. The joints in my hands, doctor.
Okay. Okay. So, are you having difficulty with your activities, like day-to-day activities, with this joint problem?
Yes, doctor. I'm having some difficulty. Sometimes I feel joints are kind of tight.
Okay. Have you noticed that it is slow in the mornings?
So what is slow in the morning, doctor?
The movement of your hands, you are not able to move your joints.
Movement of my hand is the same, doctor, all the time.
All okay, okay. So any change in the temperature of the joints?
Temperature of the joint. How I will see temperature of my joint, doctor?
do you feel that it is warm compared to the other parts of the body?
No, doctor.
Okay. Okay. So, do you have any rash?
No, doctor.
Okay. So any abnormal shakiness of the hands
No,
or
doctor.
legs?
No, doctor.
Okay. Any lumps or bumps in the body?
No, doctor.
Okay. So any pins or needle sensations anywhere in the body?
No, doctor. There is no pin, no needle, doctor.
Okay. Are you diagnosed with any condition before that I should be aware of for which you are taking any medicines?
Like what, doctor?
Any joint diseases or any heart diseases?
Like what? No, no, nothing.
Okay. Any sugar,
No,
high
no,
blood pressure? Nothing. Okay.
no,
Are you on any medications at all currently?
no, doctor. I'm not on any medications, doctor.
Okay. Any over-the-counter medications?
Absolutely not.
Okay. Any herbal remedies?
No, doctor.
Okay. Any allergies?
No, doctor.
Okay. Can I ask a little bit of personal questions, if I may?
Absolutely. You can go ahead and ask, doctor.
Okay. Do you smoke?
Yes, I do smoke.
How much do you smoke?
5, 6 sticks a day, doctor.
Okay. How long have you been smoking?
I've been smoking for quite a while from now, doctor. I mean, maybe
Okay.
5, 6 years, maybe I would have been smoking.
Okay. So I would like to ask you to stop smoking at the moment.
Okay.
If you have having any difficulty with quitting the smoking, we can refer you to smoking cessation clinic for your benefit.
Okay, doctor. Thank you so much.
Do you drink alcohol, Mr. Ramesh?
Yes, I do drink alcohol, doctor.
How much do you drink?
Doctor, I drink like maybe a glass or two per day.
Oh, okay. Of what?
Gin, doctor.
Okay, fine. Since how long you were drinking?
10 years.
Okay. Any medication, any illicit drugs, any party drugs you are having?
Oh, no, no, doctor. Never.
Oh, okay, okay. Do you have any casual relationships?
No, doctor.
Okay. So, whom do you live with, if I may ask?
My wife, doctor.
Okay. So, I think you are having problems managing your day-to-day activities with your joint pain and your decreased urinal.
Yeah,
Is
sometimes
it
I do, doctor. I do. Sometimes I feel tired also. There is some issues with that.
okay? So, you require help from your wife
Record what help, doctor?
for managing your day-to-day activities, like helping you take bath, buttering clothes, or anything
No,
like that.
no, 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 doctor. The condition is
Okay.
not worst like that yet.
Okay. Okay. Now, what do you do for a living?
Doctor, I am a mason, stone mason. Doctor, your 8 minutes is over.
Okay. So, is this affecting your work?
Yes, of course.
Okay. Anyone in your family has this problem?
Nobody, doctor.
Joint problems or any heart
No,
problems or anything?
no, no,
Okay. So have you traveled anywhere recently?
nowhere, doctor.
Okay. Can I examine you now, Mr. Ramesh?
Pleasure. Go ahead. What do you want to examine? You have to tell me.
Sir, I have to see the hands first.
Okay, I'll show you the hands. Okay, these are the hands. See the hands. This is my ward case only. See. All of you have to examine in the with the pillow, but there only towel for patients also. It's a government campus, so I couldn't keep the pillow. Otherwise, you have to examine at the pillow. Yes, doctor, tell me what else you want to know.
I have to check pulse.
What pulse? Whatever
Pulse.
given outside, doctor.
Uh, okay, sir. I would like to offer blood pressure.
Blood pressure, whatever blood pressure that is given outside.
I would like to check the oral cavities.
For what, doctor?
For that angular, the source he was telling, the corner of the mouth.
Yes, now
And okay.
the hands. Yes, tell me what else you want to see.
Then I would like to check for lymph nodes.
There are no lymph nodes.
Okay, I'd like to auscultate the base of the lungs.
Base of the lungs. Okay, nothing is there.
I would like to look for the abdomen, palpate the abdomen.
What do you want to palpate in abdomen?
Superficial, and then to look for renal, any kidney palpation.
Kidney. You feel like the kidney will be enlarged here. Nothing is there. You have 50 seconds.
I'd like to check for renal brewing.
No, not that. Yes.
I'd like to ask.
You can address the concerns. Your time, sir.
Okay. So, Mr. Ramesh, what is that is worrying you?
Doctor, what is happening to me, first of all?
Mr. Ramesh, after talking to you and examining you, I have few possibilities in my mind. I think the problem is that there is some misdirected defense system which is affecting your different parts of the body, along with your kidney, which is causing your low urine output. Is there anything else?
So, what can be done for that now, doctor?
We have effective treatment options available at the moment, which can control to some extent this disease. We can form a multidisciplinary team. We can involve kidney doctor. We can involve joint doctor, and we can help you out.
You can help me out. That's so kind of you, doctor. So, is it curable? So, right?
It is for it to say if this is what we are suspecting, it may not be curable, but it can be kept well under control with medications.
Time's up. Can you tell me a positive physical findings here?
So on examination, this patient had tightening of the skin, clubbing was present.
Then
that is what I could appreciate.
Okay. Did you see the mouth opening?
Sir, no source, nothing was mentioned, sir.
Did you ask about mouth opening?
No, sir.
You didn't. Okay. Did you see the bag? Did you ask to check the bag for salt and pepper rash?
No, sir.
Joint examination.
Hands, I saw, sir.
You didn't do.
Okay.
Okay. Can you tell me a differential diagnosis? I want 3 to 4 rational differential diagnosis for the condition.
Sir, I would like to involve scleroderma renal crisis.
Scleroderma renal crisis. Next. Next.
Sir, renal failure secondary to other autoimmune conditions.
Renal failure secondary to other autoimmune condition. Next. Nothing.
That's all I can think of.
What are your investigations? What are the specific investigations you are going to do? Supposedly, if this patient is right in front of you, what are the investigations you are going to order?
Okay, sir, I would like to first do an ultrasound abdomen.
USG. Then?
Yes, urine routine examination.
Urine routine examination. Then?
Then X-ray of the joints. Small joints of the hands.
X-ray joint of hand. Then?
Then chest X-ray.
Chest X-ray.
Then I would like to do screening. First, I'd like to do a full blood count and autoimmune workup, including ANA, anti-SCL, anti-topoisomerase antibody, and
what is more specific antibody, doctor? In this condition, which antibody is more specific? Okay, how are you going to treat? What drug you will give now?
Sir, I would like to sir, immunosuppressants. I would like to consider
presence now?
Sir, pain, first to relieve the pain and pain in a methotrexate. I will involve patient education and counseling, sir. I will do. Then I will involve a multidisciplinary team, including rheumatologist,
Okay.
uh, uh,
Doctor,
nephrologist.
what you are most worried about here? This patient's joint pain you are most worried about now, or something else? What?
Sir, renal involvement, sir. Renal involvement, sir.
Renal involvement. So what you will give?
Sir, AC inhibitors, ARBs,
AC inhibitors. Okay.
ARBs. Then um, that's all I can think.
That's all. Which drug you won't give?
Steroids, sir.
Okay. Fair enough. I'll just stop you here. I'll come to you. Your history taking is okay. You've done well. You won't blame me. However, there are a lot of other ifs, ands, and buts. I'm going to tell you. First thing, an examination of systemic sclerosis. You can kindly go to my our website, www.pacesdiaries.uk. Art of physical examination, click rheumatology, systemic sclerosis. Everything has been explained. Keep the pillow, start from the fingertip, okay, all the way to the legs. For edema, you have to examine. Abdomen examination specific for renal. Okay, see the patient here. Clean scleroderma case. See the hands. Full skin tightening is there. He had a full-blown skin tightening. There are nail changes there on both sides. This patient had a crisis. Okay, he had oliguric renal failure. He had renal crisis. Okay, they did a dialysis. He didn't want to show his face, so we didn't show his face. Otherwise, I would have shown all the findings also. This patient indeed had a scleroderma renal crisis. Okay, that's what he had. All right, this is his hands. Okay, sometimes if they want to calibrate this case as something else, then they may even give some sounds also. They can add some sounds. I mean, like there can be some respiratory. I'll just show you that. If you auscultate the kidney, like what is this? Dr. Thomas, what is this?
Sir, renal bruise, sir.
This is a
Renal bruise.
okay. You didn't have time for that. That's why I didn't play. I just bypassed it. Next thing here. Okay, so your systemic examination should be very systematic here. It will go into a borderline. Then coming to identifying physical signs, if you didn't tell renal bruit, and if you didn't check for salt and pepper rash, didn't check for the mouth opening, pallor, then there is going to be a problem. If it is a guy, it's easy to auscultate. If it's a woman, for everything you have to ask permission, and all the things are there. Coming to differential diagnosis. Okay, we have taken a survey of PACES examination in Indian centers along with RCP Edinburgh. The survey clearly states identifying physical signs is the first skill most people fail. Followed by that, the next skill most people failed in the last two diets is differential diagnosis. The reason is they are not expecting some random differential diagnosis here. You cannot go ahead and tell, like, some vasculitis causing renal failure or some other autoimmune disease causing renal failure. Where does other autoimmune disease coming here? All the things you have to think before a differential diagnosis. Your differential diagnosis should be aligned very systematically, and you should know some basic pathogenesis. Then only you will line it. So, what causes scleroderma renal crisis, doctor? Can you tell me? Can others type some differential diagnosis in the chat box? It's open. I just muted the audio for some safety purpose of you all. What causes this? What could be the cause? What causes a scleroderma renal crisis, Dr. Thomas? Why?
Sir, steroids.
Doctor, is there any steroids here?
In this case, it is not there.
Why there is a renal crisis in scleroderma? If you know that, then your differential diagnosis will be aligned up. What British Society of Rheumatology says, what up to date says. I'm going to type those things. Excellent. Dr. Panjamugi, perfect. Thrombotic microangiopathy. Okay. It's a thrombotic microangiopathy. This is the reason why there is a renal crisis in scleroderma. When there is a thrombotic microangiopathy, what can be done? What can be listed as differential diagnosis here? Fantastic. Some differential diagnosis you have to give here are scleroderma renal crisis, SRC, scleroderma renal crisis, closest differential diagnosis, renal artery stenosis, your hemolytic uremic syndrome, your TTP, okay, down the line, your malignant hypertension. These are all the differential diagnosis you have to give. Did you offer to look at the patient's fundus?
No, sir.
Should you see or not?
Oh, yes, sir. Hypertensive changes.
What be there in the fundus?
Retinopathy, sir.
Yes, you have to offer fundoscopy. They'll clearly write here. Didn't check fundus. Didn't auscultate kidneys. This will be there if you are in category B center. Category C center, straight away they'll mark unsatisfactory. Even if you tell scleroderma renal crisis, keeping a patient like this, okay, and then asking you to find there is a scleroderma renal crisis is not a big deal. But what are the differential diagnoses? This is why second most common skill that people failed in the last two diets in India, we have 200 people surveyed. 200 people I surveyed with. The second most common skill they failed and the candidates found difficult is differential diagnosis for the same reason. You should be having a thorough idea of what differential diagnosis you should give. So DD here will become borderline again if you don't give all this. Coming to clinical judgment, I kept asking you what treatment, what are the specific antibodies, and then again the routine syndrome has started. What is a routine syndrome? Talking about the same word like in India, routine, baseline. You don't tell these things to examiners, they'll be utterly disappointed. I asked you, what is the specific antibody here? What is the one antibody that will cause increased risk? I had clearly asked you.
Forgot, sir.
Okay. So another question somebody asked, some glomerulonephritis. I don't know like where it went. Okay. All right. Something was there. RPGN you cannot give straight away, doctor. TTPHES, yeah. It's just a DD for thrombotic microangiopathy. So next DD is always going to be renal artery stenosis. Down the line, you can give this 3 DDs because that's the same pathogenesis here that causes renal crisis. All right. Other vasculitis or chronic renal failure or acute renal failure is not the differential diagnosis. Malignant hypertension is one of the very important differential diagnoses. So do renal artery stenosis here. All right. So the most important antibody you should be aware of is right here, anti-RNA polymerase 3. This increases the risk of scleroderma renal crisis. Right? Very, very important. So then also the other thing is steroid usage. If the glucocorticoid intake is around more than 15 milligram per kg, okay, for 6 months, that itself can precipitate scleroderma renal crisis. Another drug I asked you, there's a drug called cyclosporin. I hope you know that, right? Cyclosporin can increases the risk of renal crisis. And initially you were telling it's curable. So don't give any false reassurance. It's curable. Don't worry, come on. You'll be all right. You can go home. No. I'll tell you the numbers. Numbers speaks. The numbers are around 22, now up to 50% of them will land in dialysis and renal transplant. So you have to warn them. All right. You have to warn them. All right. So these are the causes of the renal failure here. If they ask you what are the differential diagnosis of scleroderma, Then you can tell morphia, then you can tell mixed connective tissue disorder, then you can talk about other things. But the renal failure, these are the specific things you are supposed to address and you are supposed to tell. So clinical judgment, again, it will go into borderline. All right. Managing patient concerns, fine. Welfare, fine. I'll tell you how to manage this. This is the management of scleroderma renal crisis in UK settings. So what do? Immediately check the blood pressure, assess the severity. Okay. If the systolic blood pressure is more than 180 and diastolic blood pressure is more than 110, same thing they can ask you in your NHS interviews also. So please pay attention. All right. Aim for reduction in systolic blood pressure of around 20 millimeter of mercury and diastolic blood pressure of 10 millimeter of mercury. Okay. Then oral hypertensives, antihypertensives, I'm sorry, long-acting AC inhibitors like your Ramipral. Start at the dose of 5 milligram. All right. Okay. You have to start and increase the dosage. Second line, ARB. Third line, calcium antagonist. Fourth line, alpha blockers. If it is not resolving or if the patient is severe, okay, then immediately in a severe state, then go for HDO, ITU admission, and then you aim to reduce the blood pressure around 10 to 20% within 1 hour. The target diastolic blood pressure is 100 to 110 millimeter of mercury in 24 hours. Here you can use oral therapy and IV vasodilators. Okay, what are the IV vasodilators you can give? IV nitrate. And then suppose the same patient is presenting with other clinical features, what you are going to do? In case of seizures, IV phenytoin, you have to do brain imaging. In case of pulmonary edema, IV vasodilators. Tachycardia, beta blockers. Severe acute kidney injury. If creatinine is more than 3 times more than the baseline, or any oliguria, any hyperkalemia, what you are going to do? Straight away dialysis. All right, straight away dialysis. They can very well ask you about KDIGO criteria for AKI. What is the KDIGO criteria for AKI, doctor? When you call an acute kidney injury, Dr. Thomas.
So urine sodium.
Urine sodium. KDIGO clearly says 3. 1, 2, 3. Examiners asked this. What are they? If there is increase in serum creatinine of around more than 0.3 milligram per deciliter within 48 hours, all right, or more than 1.5 times increase in baseline from the baseline. At least remember these two things. With oliguria and urine volume less than 0.5 ml per kg per hour for 6 hours, you have to call your nephrology friends. All right. This is very important, very, very important case. This is your renal bruit. This is scleroderma renal crisis. The cases which we are going to discuss right now are the cases came in the last 2 diets repeatedly. All right. Those are the cases we are going to discuss. And we will now move on to the next important case that has come in the last 2 diets. And I will unmute Dr. Abash Jain. Dr. Abash, are you ready? Dr. Abash, are you ready?
Yes, I'm ready.
Okay. I'm just going to give you the next case. It's again a very important case that has come in the last 2 diets. All right.
Okay.
Yes, doctor. Here is your case. I'll give you 5 minutes. Okay. Please prepare.
Okay.
I just posted our group link. Who just asked, just you can join us anytime. Our sessions are free on the weekends, and our website is completely free to access. You can find most neurological signs and other signs and examination sequence. Our free podcast is there in the YouTube channels. Everything is free for you all to utilize for your PACES preparation. Please go through them. It will help you out. All right. We'll start in another 5 minutes. Now let him prepare. I'm sorry, doctor. One question came. Which platform? Which platform? What, doctor? Most of them are in Zoom, doctor, and the YouTube sessions you can directly stream. Renal crisis, differential diagnosis and management. I'll come to that, doctor, in just let this case get over. I'll revise this case and the other case. Sure. In 5 minutes, what you have to do, I'll explain that also, doctor. That is explained in my YouTube videos. If you can go to my YouTube videos and PACES introductory session, it is mentioned there. Just take the piece of paper. Here you write the differential diagnosis. Here you write the formula which I explained there. It should be more than enough. Even my differential diagnosis lecture is free in YouTube. You can listen to that, and most neurology podcasts I have uploaded. Rest I'm going to upload all abdomen, your cardiology and and your respiratory, that is pulmonology and clinical consultation podcast, and all some patient examination videos also there. And we are running our online courses every month with AstroSet. We are taking very limited number of people and running, and we have our offline courses with PACES Pro and Pass the PACES Chennai. and also many free PACES session across India and in UK. All right, just free sessions. Anyone can walk in for a ward rounds with us and be a part of this. Okay, all right. I think Dr. Abash must be ready.
Yes, ready.
Yes, go. Your time starts.
Okay. Good evening. I'm Dr. Abbas Jain, one of the doctors today in the clinic. May I confirm your identity as Mrs. Sana Smith, 38 years?
Yes, doctor. I am Sana Smith. I'm 38.
Okay. Can I call you Mrs. Smith?
Yes, you can call me Mrs. Smith.
Okay. So, Mrs. Smith, I am here to take your history and do your examination.
Yes,
Meanwhile, I'll be making few notes that will be totally confidential to me. Is it okay with you?
yes, doctor. It's okay with me. Go ahead.
Yeah, from your clinical notes, I came to know, Mrs. Smith, that you are having back pain. Can you please tell me more about it?
Doctor, my back is hurting, doctor. Severe back pain, doctor.
Okay. Can you tell me the exact location where the pain is?
Doctor, it's in my back, doctor. I think somewhere around the mid to lower back, doctor.
Okay. And when it started?
Doctor, it's been, I think I'm noticing this for the last, around the last 2 weeks, doctor. It's worst, doctor. Not able to bear, doctor. It's very much hurting me, doctor.
And what were you doing when it started?
Nothing, doctor. I just woke up and I woke up with pain.
Okay. And what is the quality of pain? Like it is a dull type of pain or it is throbbing in nature?
I
Can you
don't,
explain?
I don't know, doctor. It is pain.
Okay. So is the pain radiating elsewhere from the back?
No, doctor. It is around the back.
Okay. And to grade the pain, 0 for minimum pain and 10 for maximum pain, how will you grade it?
6 to 7.
Okay. Okay. Anything which makes this pain better?
Nothing. I tried
Anything which makes it worse?
paracetamol and all. No use.
Okay. And the pain is more in the morning hours or in the evening hours?
The pain is there 24 hours, doctor.
Okay. So when you go for your work or daily routine after getting up, does the pain increases or it remains the same?
The pain is always there. It is always same.
Okay. So do you have any like long-term history, like any history of raised blood pressure or raised blood sugar?
I don't have raised blood pressure. I don't have raised blood sugar.
Okay. Any other long-term illness which you want to share with me?
I have asthma, doctor.
Okay. So for this asthma, you are taking any medicines?
I'm taking a lot of medicine, doctor. I'm just like, I've been
Can you
given,
please share the list of?
yes, doctor. I've been given this some salmeterol, some formoterol, then this montelukast, budesonide, and multitude of medication, doctor.
Okay, these all medicines which you told you are taking by inhaled route. Any oral medicine by your mouth you are taking, if any?
Doctor, montelukast I'm taking by mouth only, doctor. Then from how else?
Okay, any like steroid medicines you are taking?
I don't.
Oral?
Oral, I was given, doctor. Sometime back, my asthma became severe. They gave me through blood channels and they gave me some oral at times. And also this, this inhaler. I don't know. Budesonide is what, doctor? Is it steroid? I don't know.
Yes.
Okay, doctor.
Okay, so by any chance are you pregnant, Mrs. Smith?
No, doctor. Why?
How are your periods?
But it's a fine, doctor.
And are you taking any pills, birth control pills?
No, doctor.
Okay. Do you have any other joint pain other than your back pain?
Sometimes even my thighs and legs are also hurting, doctor.
Okay. Any joints are not having pain like your knee joint or some other joint?
What, doctor? Joint doesn't have pain. What you're talking?
Yeah.
No, no.
Any? Okay. So, do you have any difficulty or in getting up from sitting position?
Sometimes I do.
Okay. And do you have a rashes or discoloration of skin anywhere in the body?
Some skin changes there, doctor. I don't know what is it.
Can you please show me?
So I'll show you, Dr. Moses. See, I have this thing in my tummy, doctor. It's very embarrassing.
Okay. Do you have any excessive hair growth in your body? Anywhere?
My
Like in your face?
my hair growth is more in my hair, doctor. Nowhere else. See, this is in my tummy. Okay, this is in my hands.
Okay. Okay. And do you have any fever?
No,
Raised
doctor.
body temperature? Do you
No.
have any weight in, like you have gained weight in past few months or days?
What? No, doctor. I'm gaining weight not just past few months, for quite a long time.
Okay. Okay. So how is your appetite?
My appetite is increasing.
Okay. And how is your mood?
Terrible, doctor. Pathetic mood.
Okay. I'm sorry to hear about that. I'll try to help you.
Oh,
And any lumps and bumps over your body?
no lumps and no bumps, doctor.
Okay. Any abnormal shakiness in your body?
No, doctor.
Okay. Any pins and needle sensation in the legs?
No, doctor.
Okay. Any headache?
No headache.
Any problem related to your vision, such as redness of the eyes or
No,
difficulties?
no, doctor.
Okay. And any weather preferences?
No, doctor.
Any giddiness on standing from sitting position?
No, doctor.
Okay. And any shortness of breath?
No, doctor.
Any chest pain?
No, doctor.
Any racing pacing of your heart?
No, doctor.
Okay. Any cough or shortness of breath?
No, doctor.
Okay. And difficulty related to your waterworks?
No, doctor.
Any difficulty related to your bowel works?
No, doctor.
Okay. Any history of allergy to any medicines or any food substances?
No, doctor.
Okay. Have you previously been hospitalized for anything?
No, doctor. Like I said, only for asthma.
Okay. And any uh, disease which runs in your family you want to share with me or you're aware of?
What, doctor? Nothing I am aware of, doctor.
So anything you have been operated for before?
No, doctor.
And I will ask you a few personal questions. Is it okay with you? Do you
Yes,
smoke?
yes, I do smoke, doctor.
Okay, I'll advise you to please stop smoking because it is any amount is harmful and you are already having this condition of your lungs, bronchial asthma. So please stop smoking and I'll refer you to our smoking cessation clinic.
Yes, doctor.
Is it okay?
I will try, doctor. Your 8 minutes is over.
Do you take alcohol?
Yes, I do take alcohol, doctor.
How much?
I take just 750 ml, doctor, on the weekends. I get one bottle, I divide the bottle into three equal halves, and then I drink.
Okay, any party drug or illicit drugs?
No, doctor.
Okay, I will like to examine you, Mrs. Smith.
Okay, sure, you can.
I will like to check your pulse. It is regular.
Pulse, whatever is given outside, doctor, it's regular.
Okay, I like to check the face of the patient for any puffiness.
Yes, it is there.
Okay. And I will like to check for any pallor.
No pallor.
Okay. Next, I would like to check her back and check for any uh, restriction of the movement of the back.
Yes, there is restriction of movement. I can't show her face because patient is not willing to. Yeah, tell me.
Okay. I will like to check the abdomen, palpate the abdomen for any organomegaly.
There are no organomegaly. Which organ you want to be enlarged here? Or which organ you think that will be enlarged here?
Any hepatomegaly?
No,
Okay. And any renal mass if it is palpable?
no renal mass.
Okay. I like to check the hands of the patients.
For what?
or any nail changes or palmar erythema?
No.
Okay, next I will to check for basis of the lungs for any crepitations.
No, doctor. No. You have 30
Like to check for pedal edema.
You have 30 seconds left. Yes, no,
Pedal edema.
done. Time's up, Dr.
I
Abhay.
will offer fundus examination.
Fundus examination. Okay. Please go ahead and address the concerns.
Okay, may I know what are your concerns, Mrs. Smith?
Doctor, I have a lot of concern, doctor. Why I am having this pain, doctor? My back pain is horrible.
Okay, I will try to help you, Mrs. Smith. What I think that since you are having this condition, bronchial asthma, and for that you are taking this medicines off and on that we call as steroids, and due to that medicines your bones have been weaker, and that's why you are having this skin changes and you are having weight gain, and that's why that is the cause for your back pain.
Oh my
Is it
God.
making sense?
So the doctor,
Yes.
they used to say that you know, this asthma doctor, the lung doctor, actually given me this drug to cause all these things. I'll just sue him.
That's not like that, Mrs. Smith. We always, when we give any medicine, we think if the benefit is more than the risk, then we give that medicine. And to control that asthma, that medicine must be required to be given to you. Is it making sense? Any
Oh,
more concerns?
doctor, is it curable, doctor? Now, if I stop the medicine, now my bones will be fine.
That we have to evaluate you with our lung specialist that whether you require these medicines, and
Okay,
that medicines cannot be suddenly stopped. They need to be tapered off slowly.
it needs to be tapered out. Okay,
Yeah,
doctor.
slowly they have to be decrease the dose and they have to be stopped.
Your time's up. Okay, can you tell me
Yes.
about the physical findings here, doctor?
This 38 years old lady, she is having a puffy face. She is having a proximal myopathy on examination. She has having striae in the abdomen and in the arms. And uh, yes,
Then
this much I can.
puffy face, try in the abdomen.
And on examination of the back, there is a restricted movement of the back.
Okay. All right.
Proximal myopathy is present.
Present. Did you examine?
I asked,
Asked what?
honestly, I asked that there is difficulty in standing from sitting position.
You cannot tell any finding which you asked in history for physical examination. Okay.
Okay.
Be very honest. Unless you examine, you do. Without examining, don't go and tell proximal myopathy is present in this patient. Okay. You didn't examine. You are supposed to examine. Many things you
Okay.
examine. So tell me a differential diagnosis, doctor.
My first differential diagnosis is steroid-induced osteoporosis in a case of bronchial asthma.
Steroid-induced osteoporosis. Next.
And proximal myopathy due to any other cause which I need to rule out, such as Cushing syndrome or hypothyroidism.
3, 4. If you tell 4 here, you will tell at least 2, 3 there in exams. Next.
Okay. So, steroid-induced Cushing syndrome.
Steroid-induced Cushing. Okay. So how are you going to investigate?
Okay. I will check her CBC for leukocytosis or any neutrophilia, and because she is having bronchial asthma, also for eosinophilia. I will do DEXA scan of the bones to check for osteoporosis,
Okay.
and I will also do a thyroid function test.
Okay.
I will also do early morning urinary cortisol, 24 hours urinary cortisol levels.
Okay.
And I will do a pulmonary function test to check whether a bronchial asthma is under control.
Okay.
And serial PEFR monitoring, and try so that the steroids can be tapered off.
Okay. What tool you will use to quantify osteoporosis? You want to
T-score, T-score, T-score.
T-score.
Yeah.
T-score you will use to quantify. Anything else?
It is less than minus 2.5. That is osteoporosis.
So, okay, what drug you will give for that?
The drugs which are used in starting are biphosphonates, alendronate and zoledronate, and patient needs to be yes.
All these three
No,
drugs together you will use.
no, any of them I will start
Okay,
along with vitamin D supplements and calcium.
vitamin D supplements. So, what will be the calcium and vitamin D levels in osteoporosis, doctor? What will be the vitamin D and calcium levels in osteoporosis?
Normal.
So, will giving this externally will help?
No.
No, right?
No.
Then suppose this bisphosphonates which you are telling are not helping, what drug you will give?
Another choice are denosumab, which is given subcutaneously once in 6 months. It is a better drug. And another drug is strontium ranolate, but it cannot be given in if there is a risk factors for coronary artery disease.
So, what advice you will give before starting a patient on bisphosphonates?
First, patient has to be empty stomach and he has to sit down and he cannot lie down for 30 minutes after taking the drug. And because there is a serious side effects of esophagitis when bisphosphonate is taken out.
Okay. All right. Your time's up. Done. Okay. All right.
Okay.
Messages has come. A good sense of humor. Thank you so much. We have to be humorous, then only we will keep ourselves light. There's no point in being hard. All right. So go to this case. Dr. Abash has finished this case. All right. Osteoporosis is one of the DDI, don't deny. Let's start from history taking. Okay. Doctor, did you ask what she's doing?
Job, I forgot to ask.
And driving is not relevant, but still keep the habit of asking driving. Okay. Social history not asked. Did he ask, is she taking any pills to postpone the pregnancy?
That I asked.
That you asked.
Pills about pills I asked.
Did she ever pregnant? Those things you asked. All right.
Yes.
You were asking about alcohol and how much she is drinking.
3 units on the weekend.
No, what she said. I get a 750 ml bottle. Clearly see the recording. I'm so sure about what I told. I
cannot hear properly. You are right.
Yes, clearly I recorded everything. I take 750 ml and in the weekends I will divide into 3 parts and drink. I never said 3 units because no patient or no surrogate will tell in unit. So 750 ml is one full bottle, right?
Yes.
Full bottle somebody is drinking on Friday, Saturday and Sunday, and you are not at all talking about stopping the alcohol, then that is ultimately against the patient's welfare. You are supposed to tell him, kindly do not drink alcohol, kindly cut it down. This can have deleterious effect.
The 750 ml is beer, one bottle of beer.
One bottle of beer is not 750 ml, doctor. 750 ml, that to one bottle of beer, nobody can drink over 3 days, doctor, because once you open, it's gone. Because I don't want to explain so in detail. People shouldn't end up thinking this guy is a bartender or what. One bottle of beer is done. You open, bottoms up. 750 ml is something you use for hot drinks or hot drinks. All right, your rum, whiskey, brandy, gin, all right, all these things are 750 ml. So this lady is getting one full bottle and drinking for 3 days. It means she is an alcoholic. And cage question was not explored. Alcohol cessation was not done.
We're short of time. Yeah.
We'll be going for a borderline. If you beat around the bush, all right, cage quickly you do it. Entire cage you need not do. At least tell, have you ever felt like you need to cut down the alcohol?
Okay.
Are you feeling guilty about drinking? Any two, at least ask. And just tell, even if you don't mention cage, you have to mention AA. What is AA? There is a group of people called Alcoholic Anonymous. They're in UK. They're in UK. Funny thing is, in that group itself, couple of people are goosards. They get drunk, come on the weekends and give nice advice why you shouldn't drink alcohol. All right. So Alcoholic Anonymous people, she should be referred to. This will go against the patient's welfare. If you are not stopping driving in appropriate situation, it will go against the patient's welfare. They will cleanly mark you here. I even in the one of the free session, after attending an examiner's meet with my brother, and I just came and gave you all the information line by line. I gave you what are the new things they added for PACES 2025, including verbal roughness. All right. Next thing, physical examination without seeing proximal myopathy, and you didn't even palpate the spine. Instead of that, you are checking the movements. First thing itself, you have to go and ask where exactly it hurts, ma'am. Can I just touch and feel? Didn't do that. Spinal tenderness was there. Okay. So coming to the clinical judgment, you're told all the diagnosis. Okay. I asked one tool. There are a couple of things. Other than DEXA scan, there is something called a FRAX tool. Please go and read about it. There is something called a FRAX tool, which we use. And then again, maintaining patient welfare is fair enough, but sometimes you can get marked down here if you are not asking to stop alcohol. Okay, coming to differential diagnosis, this is a case of osteoporosis. And what diagnosis you gave? Steroid. And then you went straight away for proximal myopathy. Is that a proximal myopathy here? Is there a proximal myopathy here? Is that a diagnosis for the back pain? Dr. Apash, are you there?
Yes, I am there.
Okay. So what are the differential diagnoses here? Steroid-induced osteoporosis.
Yes, it can be like prolapsed intervertebral disc.
That is later. Next thing,
Okay.
Cushing's itself can cause osteoporosis.
Okay.
It can be steroid or she has a Cushingoid features even before steroid. Nobody knows that itself. Steroid can directly induce and Cushing also can induce. Then any prolapsed IV disc can cause severe pain like this.
Okay.
Suppose the same patient is coming with pain in hip. What are the differentials? Others also. Pain in hip.
Avascular necrosis of the hip joint.
Yes. Pain in hip, AVN. All right. Okay. I will ask you one more question. This lady, you have seen, this lady is obese. Okay.
Yes.
You are seeing another lady and maybe 40-year-old, well built, like thin, who is at high risk of osteoporosis. An obese patient is high risk of osteoporosis, or a thin patient is in high risk.
Inbuilt, no BMI, no BM.
Sorry?
Inbuilt is more at risk of osteoporosis.
Yes. A thin build person is more at risk of osteoporosis than obese patient. Second, this much of alcohol intake itself can cause pseudo Cushing's. What are the causes of pseudo Cushing's? Doctor, what are the causes
Alcohol
of
depression, alcohol abuse.
Okay. All right. Both can cause hypothyroidism, alcohol, depression, again, all these things. So you have to give these differential diagnosis. Suppose if it is an elderly lady, another case came, elderly lady with the back pain, what you will think of? With some weight loss, with some night sweats.
First is pot spine, second is the secondaries in the spine.
Yes,
Or
exactly.
multiple myeloma.
Yes, in India, you should also think of pot spine. Everywhere TB is there. And many people now, a recent survey taken by one of my friend who is a pulmonologist, latent TB is there everywhere. If you put, very well, right? Most people are walking with latent TB. You and I definitely will test positive, right? Won't we? Everywhere it is there. So that can be also another differential diagnosis. So your differential diagnosis should be on spot and spot on. It shouldn't be ifs, ands, and buts. All right, this is the case. Quickly, I will just do one thing. Somebody asked about discussion on management of scleroderma renal crisis. Quickly, I will revise you. Scleroderma renal crisis, okay. Steroid-induced myopathy is not a DD here, doctor, because myopathy will not typically present with the back pain with spinal tenderness. All right, myopathy will not. Proximal myopathy will be present with some weakness that particularly affect the proximal muscles. All right, scleroderma renal crisis, the drugs you need to think of: blood pressure, systolic blood pressure more than 180, diastolic more than 110. If it is not, you can try oral antihypertensive like AC inhibitors, ARBs, calcium channel antagonist, all right, and doxycycline. Suppose if it is more than 180 and 110, admit to HTU because those are high risk cases. All right, target the diastolic blood pressure for 100 to 110. Then give IV vasodilators like nitrates in addition to oral therapy. Then if you see here, if they are presenting with seizures, give phenytoin, pulmonary edema, vasodilators, tachycardia, you give beta blockers. In severe AKI, I just explained about KDIGO criteria that you can find on internet anywhere. In that case, you have to go for dialysis. All right. And another question that has been asked by the candidates is here. This is one of the things. Okay. Cushing syndrome, if you want a mnemonic, these are the things. Cushing syndrome, about that very clearly we have mentioned already in the website. Kindly go through that. And one candidate asked what to do in the 5 minutes. Please use the 5 minutes efficaciously. See, this is the paper you will be given. On this corner, you write the differential diagnosis. Immediately write whatever it is. Here you write IVAP. What is IVAP? Introduction. You introduce yourself. Next, verification. Verify who is the person is. Then A for agenda. What is your agenda? Why are you there? And P for permission. I'll explain you. Mrs. Smith. If I'm talking to Mrs. Smith, I'm going to talk to Mrs. Smith. In a UK setting, what I will do, I'll just go ahead and say, hello, good morning. I'm Dr. Moses. I'm one of the medical doctors from infectious diseases department. I've been asked to talk to you. May I just verify you are Mrs. Smith, 38 years old. She will tell you, yes, hello, Ms. Smith. How are you doing today? Yeah, are you comfortable right now? Okay, I just got a letter from your general practitioner or from some trust or whatever it is that you are having some back pain. I'm here to talk about that. And after that, I'm going to quickly examine you. We're going to look for a way forward from here. Is it okay? Permission. So you're introducing, verifying the identity, set the agenda, ask the permission. That's the first thing I want you to write. Then immediately specific questions for back pain. Then after that, systems review. You can watch in the YouTube. We had already thought where head to toe systems review, how it has to be done. Then quickly go for past history and as well as medication history. In the past history, even the surgical and procedure history is important. Medication, you should ask about the dosage, amount of medication, any change in the dosage, plus allergic history. This is for both allergy to food as well as medicine, and any over-the-counter medication or a herbal remedy. Then you have to ask about social history. Along with that, please try to include driving. Wherever appropriate, travel history and family history. Then comes your personal history. Personal history, all right. Your smoking, ask how many sticks, how long. Smoking should be stopped, done. Then alcohol. What kind of alcohol? How much? How long? Is there any binge drinking? Excess alcohol, stop and reduce. Then drugs, if there is an IV drug use, don't forget any needle sharing is involved. Also, you can ask about tattooing in some appropriate cases, all right? Then about sex, ask either the person having a casual partner. Also do ask openly about any men sex with men. MSM is very, very important. Even today also WHO announced some monkeypox outbreak, which is more common in homosexuals. Men sex with men, MSM sex, very, very important. So IVAP means, once again, introduction, verification, your agenda, permission. Hardly 2 minutes it will take to write these things down. And as you're taking the history, keep taking it. Done, 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 done. Differentials, write some differential outside itself, because my differential lecture is free in YouTube. I covered all the differentials. Okay. Only the sub differentials we are teaching the classes. Okay. All right. So the next case, Dr. Safin, are you there, doctor? Dr. Safin is there by any chance? It's not there. If you are there, Dr. Safin Hassan, please just uh, leave a text. Okay, this is the text. Doctor, we have a better screenshot in YouTube, doctor. The page has a better screenshot. You can do. I'll just send you all those things. No problem. Dr. Safin, are you there? Not there. Okay. Dr. Dinesh, are you there? Dr. Sunny Samuel, are you there? Dr. Dinesh, are you there? Just say hi, hello in the chat. Okay. Yes, sir, I just unmuted you. I'll just make you a co-host as well. Dr. Sunny Samuel. Okay, you two will be doing the case. I made Dr. Dinesh, I made you as a co-host. At any point, don't get disconnected. All right. Okay. The next case is for Dr. Dinesh. Go ahead, doctor. I'll give you 5 minutes. Okay. Doctor, are you there?
I'm here.
Yes, doctor. 5 minutes. And the next case, Sunny Samuel.
Okay.
Go ahead. Another question was asked, what are the complications in Cushing? Cushing's complication is head to toe, doctor. From the hair to cataract, then see the face, easy bruising, osteoporosis, it can cause impaired glucose tolerance and hyperglycemia, that related complication, high blood pressure related complications. There is Cushing syndrome spares nothing. Proximal myopathy, most everything, cardiac complication, which is the most worst outcome. Everything it affects. Just to go to my website, and there is our website, and there is there is a column called Art of Physical Examination, and see that how the examination is. The entire examination is tailored to look around all the complications also. All right. Just like I already posted, I think again I'm posting website link is here. You can just go ahead. All right. Website link, YouTube link, and our group link is here. All right, we can go there, and we will have a talk on Cushing syndrome in one of our podcasts, because our podcasts are either we invite people who are specialty trainees or consultants. Only they will come and take hand of them. Right? It's there, doctor. Differential diagnosis video is in the YouTube. Go to my YouTube channel, subscribe, and see in my videos. In one of the videos, differential diagnosis. It is there in the YouTube. All right, Dr. Dinesh, are you ready?
Yes, sir, ready.
Come on, doctor. Start.
Yeah, hi, my name is Dr. Dinesh. I am one of the doctors here. Can I confirm your name and age, please?
Yes, doctor. I am Murphy. I am 36 years.
Is it okay if I call you Murphy?
Yes, you can call me Murphy, doctor.
Okay. Mr. Murphy, I am here to discuss regarding your condition and examine you. Is that okay with you?
Yes, you can, doctor. You can.
While examining, while taking history, I'll make some notes. Don't bother, don't mind about that.
No, doctor, I won't, doctor. Dr. Dinesh, your voice is dipping in between. Please make sure you hold the mic close to your mouth and talk. Yeah.
Okay.
Yes.
Now, sir?
Yes, now it's fine. Go ahead, doctor.
Yeah, Mr. Murphy, I can see from later that you are having some vomiting. Can you tell me more about it?
Yes, doctor. I've been vomiting from morning, doctor. It's very terrible. Even yesterday also I've been vomiting.
Can you tell me when it was started exactly?
Doctor, I've been vomiting since yesterday, doctor. Continuous vomiting.
Okay, before yesterday you are completely all right?
Yes, doctor, of course.
Yeah, can you tell me how many episodes since yesterday?
Doctor, I've vomited a lot, doctor. I've been vomiting nearly for, yesterday itself around 6-7 times. From the evening, I've been vomiting. Morning also, I've been vomiting. I'm just rushed here immediately.
Okay. And along with this, do you have any kind of loose stool?
No, doctor.
Okay. And since yesterday, is it getting progressing?
Yes, it is.
Okay. Anything making better or worse this year?
Nothing, doctor.
Growing up?
I just tried drinking this antacid. It is not helping, And then my wife gave me some ginger drink. It only made it worse.
Okay. This is the first time you are getting such kind of symptoms, or earlier also you have?
First time, doctor. I never had this kind of vomiting and all stuff. This is really terrible. This is the very first time I'm getting all these things.
Okay. Did you travel recently anywhere?
Yes, doctor. I traveled just like that, but not anywhere outside India.
Where did you travel exactly in India?
Doctor, I just traveled up to Bangalore and came, doctor. Nowhere else.
And when it was?
It was around a month back.
Month back, not recently.
No.
Any street food, anything you ate like that?
Nothing, doctor.
Okay. Can you tell me, do you have any rash, anything like that?
What, doctor?
Do you have any rash?
No, doctor, I don't.
Any fever?
No fever.
Any night sweat?
No night sweat.
Any lumps and bumps anywhere in the body?
There are no lumps and bumps.
Any joint pain?
No joint pain.
Any back pain?
No back pain.
Any pins and needle sensation anywhere in the body?
Sometimes I get in my legs, doctor.
Since when it is?
I've been having this nearly for more than 2 years.
2 years. Okay. And can you tell me, did you notice any change in your weight?
I'm just not putting up weight. That's the only change I noticed.
Since how long you are not putting weight?
I've been noticing in this last 2 years, doctor. I'm not putting up weight, doctor.
And did you notice you are losing any weight?
It's not like losing weight, doctor. It's just I'm not putting up weight. I'm not losing weight, but I'm not gaining weight either.
Okay. Are you comfortable in any particular environment, like hot environment or cold environment?
I am, doctor. I am very much comfortable.
Okay. And what about your water work?
My water works, it's going a lot, doctor.
And since how long?
It's been going on, doctor. Last 2-3 years, I've been noticing I'm just peeing a lot.
Okay. Are you feeling more thirsty?
Yes, I do.
Okay. Along with, do you have any cough, breathlessness?
No,
Any racing, pacing of your heart?
no,
Any chest pain?
no, doctor.
Any tummy pain do you have now?
Yes, doctor. I'm having some tummy discomfort, and in the since yesterday it is more terrible tummy discomfort, and that's what after that I'm having this, feeling sick and throwing up.
Okay. And do you have any headache?
No, doctor.
Any problem with your vision?
No, doctor.
Okay. Are you diagnosed with any medical condition previously?
Yes, doctor.
Can you please tell me that what it is?
I've been diagnosed. They said like I have high blood sugar, and then I went and they gave me some medicine. I've been taking this whenever I feel like.
Since how long you are taking this medicine?
Doctor, for quite some years I took, doctor. Then I stopped. Like, for 5-6 years I took, then I stopped. They said I have to put this medicine, that medicine, insulin, 3 monthly blood sugar medicine. I stopped. I saw a YouTube video. In the video, they said diabetes is just a hoax of big pharma. After watching the video, I stopped.
Since how long did you stop this medication?
I'm not taking this, doctor, for the last 1 year.
Okay. And have you checked your sugar levels recently?
No, doctor. Medicine itself, I'm not taking. I know diabetes is nothing.
Okay. Apart from this diabetic, any other medication are you on?
No other medication.
Okay. Are you taking any over-the-counter herbal medication?
No, no,
Are you allergic to any medication?
no.
Okay. Anything is running in your family, the similar kind of complaint?
No, doctor.
Okay. And is it okay if I ask you some personal question?
Yes,
Do you smoke?
I don't smoke, doctor.
Do you drink alcohol?
Yes, I do.
And how much can you tell me, please?
Yes, doctor. I just drink like, every day I drink, doctor. I just drink, I get a small bottle, this 180 ml bottle of old monk rum and drink every day.
Okay. Have you ever thought of cutting down your alcohol intake?
No, doctor, not at all.
As Mr. Murphy, this much amount of alcohol can affect your health. I would like to suggest you reduce amount of alcohol intake. Is that
Yes,
okay with you?
yes, I'll try to cut it down, maybe. Yeah, fine.
Okay. Do you use any kind of recreational drug?
No, doctor.
Sorry to ask you again some more questions. Do you have any problem with your intimate relationship?
No, doctor, no problem at all.
And can you tell me what do you do for living?
Doctor, I'm an artist.
And how it is affecting your day-to-day life and work?
It was not affecting since yesterday only. Yesterday I had to miss a contract because of this, doctor.
Okay. And do you drive?
Yes, I do drive.
At this moment, Mr. Murphy, I would suggest you should not drive. Is that okay with you?
8 minutes over, doctor.
Okay. I would like to examine the patient.
What do you want to examine, doctor?
I would like to start from his hand, sir, for any nail changes, anything is there.
Nothing is there.
I would like to check his pulse.
Whatever given outside.
I would like to check his oral cavity.
Oral cavity. I'll show you his oral cavity. See his oral cavity. Open your mouth, sir. Yes. See that?
Yes.
Yeah. Then
I would like to see for pallor, sir.
there is no pallor.
I would like to check for visual acuity and just offer for fundoscopy, sir.
Fair enough. Good. There is no pallor. Fundoscopy you can do later. Then.
Okay. I would like to check vibration and the prick sensation, sir.
Vibration lost up to ankles bilaterally.
In upper limb, sir.
Upper limb it's not lost.
Okay. I would like to auscultate his heart, sir.
Non-auscultate is heart. Okay.
Yes.
Nothing is there, doctor. You have 30 seconds left.
I would like to palpate his tummy, sir.
Just you can touch his tummy, time will be over. All right, address his concern, doctor.
What are your concerns, Mr. Murphy?
Doctor, I have a lot of concerns, doctor. Like, first of all, I want to know what is happening to me, doctor. I was fine. Now what happened?
Yeah, Mr. Murphy, I can say from your examination and history that it's something related to your diabetic, for which you are not taking medication. And there is possibility that there is a very high sugar level in the body, and because of that you are developing these symptoms.
I have high sugar level in the body.
Yes, and one more possibility that your own defense system is attacking against you. That is one of the more possibility. Any other concern do you have?
I mean, what you are going to do for that, doctor?
Presently, I would like to admit you, Mr. Murphy, and would like to start you on some IV fluid and some insulin, and you need admission, Mr. Murphy.
Doctor, like
any other concerns?
Doctor, you are scaring me. Won't admit me. Is it curable, doctor?
At this moment, it can be curable if we treat properly, and you need regular follow-up regarding that, Mr. Murphy. But if it is something related to your defense system attacking, I cannot guarantee you whether it is getting progress or how.
Oh my God. Doctor, that's absolutely scary. Okay, doctor. Thank you so much. Can you tell your positive physical findings, Dr. Dinesh? What are the positive physical findings?
On examination, sir, he is having lost vibration sense in the lower limb.
Okay.
And perioral pigmentation is there, sir.
Okay. Then what are your differential diagnoses?
My first differential diagnosis is diabetic ketoacidosis.
Fair enough. Then?
And it could be related to his pigmentation, maybe Addison's disease. Addisonian crisis, it could be.
Addisonian crisis group. Then? One more. Okay, how are you going to investigate? What you will do? What are the quick investigations? Suppose this patient is...
I would like to do, sir, bedside sugar level. I would like to do for him first.
Okay, then?
I would like to send urine ketone and complete blood count, see hemoglobin and any raise
Okay.
WBC for any.
Okay.
I would like to send his ABG.
Okay. So, doctor, how will you treat Addison's crisis? Addisonian crisis, patient is there right in front of you. How will you treat?
We'll start with the IV hydrocortisone and IV fluid.
Okay.
And we'll.
How much IV fluid? How much IV fluid you will give, doctor?
First 30 minutes will give 1 liter of IV fluid.
Which IV fluid?
We start with normal saline.
Okay. How much hydrocortisone you will give?
I'm not sure, so I think 200 mg.
Okay. How will you manage diabetic ketoacidosis?
Diabetic ketoacidosis will start with the IV fluid, sir, along with this bolus insulin and infusion of insulin.
What?
Along with Insulin, sir. I would like to start insulin.
How much insulin? Doctor, diabetic ketoacidosis, if they ask everything, you should be ready to tell with dosage. Soda for additional
We'll
interest.
start from 0.1 unit per kg, sir.
Okay, then.
We'll check for electrolytes.
Okay.
We'll check for urine output also, sir.
Is that all? What are the 10 steps given? Okay, doctor, I'll stop your time, sir. Okay. Coming to your case. Did you ask about dizziness?
No, sir, I forgot actually.
Very, very important. But history otherwise okay. Coming to physical examination, it will go borderline straight away for two reasons. First of all, abdomen auscultation should be, abdomen palpation should have started little earlier than what you have done. And secondly, what you offered at the end, fundoscopy. Along with the fundoscopy, it's very important here you have to offer about blood glucose level. And apart from that, another important thing is postural hypotension is there. See here, what is the blood pressure?
Yes.
You have to offer postural hypotension. That will go off. Okay. Coming to clinical judgment. So how you will treat a patient with adrenal crisis first? I'll come to the differential diagnosis in a while. Adrenal crisis, how will you manage? First, what if, because the same question is what they are asking for, I'm sorry, NHS job interviews. So what you will tell? Same thing for PACES and NHS job interviews. Okay, I'm trying to get a critical care consultant to do all the emergency scenarios for free for all. Because in PACES, station 2 and 5, one is an acute scenario, another one is a chronic scenario. I hope all of you are aware of it. Mostly it is like that. One is an acute, another one is a chronic scenario. In acute scenario, you should be able to tell, but you should be able to tell. Not thinking this, oh, no, that, oh, no, this, no, they will judge you like that. That now getting a job for anyone with internal medicine, it's very difficult. Now, only thing people are asking, yesterday also I sent few people CV, acute medicine, give people for acute medicine. Nothing, you can only go Carol rounds with that. All right. So adrenal crisis, how do you treat? Establish large R2 IV access with a large gauge needle, a large bore IV access. All right. Then immediately draw blood. For what? Blood glucose, electrolytes, blood urea nitrogen, cortisol, and ACTH. Okay. I'll just write it here. Then 1, 2, 3. What you will do? 1 liter of isotonic saline typically preferred, or 5% dextrose. 4, hydrocortisone. How much? First 100 milligram, you give us bolus. Then 50 milligram for every 6th hourly. Okay. Then other measures, if suppose, then after that you have to taper it. Then if there is any mineralocorticoid replacement is needed, okay, then you have to also advise later fludrocortisone. What is the dose, doctor? What is the dose of fludrocortisone? You need to tell me.
Not sure, sir.
0.1 milligram. You have to give daily. Okay. This is thing. Then diabetic ketoacidosis treatment. Now we don't have time to go into that. That's something extremely common. Everyone should be aware of. All right. Diabetic ketoacidosis. Coming to the next important thing. All right. This is the treatment. So clinical judgment should be sharp, not beating around the bush. Consensus is fine. Welfare is okay. Coming to differential diagnosis. What differential diagnosis Dr. Dinesh has missed here? Of course, it's a DKA and Addison's crisis. True. What other thing can happen in a diabetic, abdominal pain, vomiting, uncontrolled diabetes? Along with that, what could be other differential diagnosis? Tummy pain, vomiting, diabetes, How much alcohol is he drinking?
Yes.
How much alcohol is he drinking, doctor? Every day 180 ml. 180 ml is how many units? Approximately 180 ml is how many units?
Around 14, 16 unit only.
14 unit. What is 1 unit? 180 ml, very good, Dr. KBR and Dr. Vandana. 180 ml is 6 units. 6 units a day. So other differential diagnosis they expected here is pure pancreatitis. These are the 3 differential diagnoses here. Very, very, very important differential diagnosis. Then you rule out all the other things. 3 things: DKA, Addisonian crisis, and pancreatitis. All right. These are the most 3 common things. Acutely unstarted one. And dizziness in the history is very, very important. All right. Please, DKA, go back and read. You take up to date, or you take British Medical Journal. If you want British Medical Journal screenshot or Harrison screenshot, anything, just let me know. I'm more than happy to send you. But it's very, very important. You should know everything. DKA, you should know everything. Everything with dosage. All right. Treatment of Addisonian crisis. Okay, NHS interview, if they are asking. Anyways, most interviews, they will already prefix whom they want to pick. And then simply they will come and sit in front of you and ask, what do you have to tell? Large IV access, then take glucose, electrolytes, blood urea nitrogen, cortisol, ACTH, quickly 1 liter of isotonic saline or 5% dextrose liter, then hydrocortisone 100 milligram bolus, then 50 milligram every 6th hourly, fluorocortisone 0.1 milligram. All right. It's very, very important. Tell this, they will understand, okay, this guy at least studied some theory and came here, even if he doesn't, never treated an Addison's crisis or not in his life. 6 units is 180 ml. He's drinking 180 ml. Okay. 2 units, allowed 2 units is equivalent to 60 ml, 50 to 60 ml approximately. All right. Screenshot I will definitely share in our group, doctor. I'll definitely do it. All right. There is a separate DKA management protocol from UK itself is there. I will rather share it. Okay. All right. Because the UK people who are watching me around, they will be little mad if I share anything from Harrison's. All right. They don't like it. Anyways, this is the case. I hope all of you got it. And I hope all of you are clear. All right. So without further, we will go to the next case. Next case is a very important case, very atypical case. I have assigned the case to Dr. Sunny Samuel. Where is Dr. Safin here? To see him. Okay. All right. Dr. Sunny Samuel, are you there?
Yes, sir.
This is one of the cases that led to failure of many people in one of the center where the pass rates are typically good. All right. Very weird one. I'm sorry that I have assigned. Okay. This is Addison's crisis management. Okay. Let's leave it. All right. This is your case, doctor. The complaint was very different. Hoarseness of voice. Okay.
Okay, sir.
And any other disease we should know about exact manner. Yes, doctor. For NHS interview and PACES station 2 and 5, emergency management scenarios, I will discuss, doctor. I had requested a critical care consultant, okay, to come for our podcast. I will record everything and I will post on the YouTube. All our videos are free. Our site is free. Everything is free. We freely receive, we freely give. Okay, no problem. You can watch. I will upload them. All right. Okay. Yes, Dr. Sunny Sam will take your time. Right, and think well what you have to ask. Okay, there is a question here. Concern, should we tell the patient that it's because of high blood sugar? Absolutely, yes. Okay. The third important column where people failed is, first I said identifying physical signs, then differential diagnosis, third concerns. You know why some people are failed in concerns? I have 7+ feedback. Okay. As a mentor from RCP Edinburgh, as an official, I'm not allowed to share the feedback. But I will tell you what exactly I've read. The patient, asking, when the patient is asking, for example, in this case, Dr. MD, to you, all right, if the patient is asking you what I'm having, you cannot brush off, you have to tell the appropriate concern. Appropriately, you have to address it, covering the differentials. That's what they are expecting. The concern should cover the differentials. So what are the differentials here? You have to talk about an uncontrolled diabetes mellitus leading to DKA. You have to also talk about Addisonian crisis. You have to also talk about pancreatitis in a quick succession. Couple of causes. We will test and we will let you know which one of the possibility. At least 1 to differential should be blended with your concern. Okay, I hope that helps. You're welcome, doctor. You all can approach us anytime for any help with PACES, moving to UK, anything, we are happy to help you. Doesn't matter you are a part of our online course or offline course. We don't see anyone like that. We see people as human beings and we help. Dr. Sunny Samuel, are you
Yes,
ready?
sir.
Please start.
Hello, my name is Dr. Sanish. I'm one of the registrars in the clinic. Am I talking to Mrs. Dorothy, and are you 43 years old?
Yes, doctor. Yes, I'm Dorothy. I'm 43 years old, doctor.
Hello, ma'am. I would be asking you a few questions regarding your complaints, and I would be noting down a few things. It will remain confidential between us. Is it okay?
Yes, it's okay, doctor. Go ahead, please.
Okay, ma'am. Ma'am, can you please tell me about this hoarseness of voice?
Yes, doctor. My voice is only like so hoarse. I don't know why. And it is very scary, doctor. My husband is telling whether I have some rat inside my throat.
Okay, ma'am. Since when have you noticed it?
Doctor, I've been noticing this for the last 10 days, doctor. My voice is getting hoarse and hoarse, like very hoarse.
Okay, so you mean to say like it is worsening as the days go by?
Yeah, doctor, it is worsening as the days goes by.
Ma'am, along with this hoarseness of voice, do you feel that you are having any breathing difficulty?
No, doctor, I don't have a breathing difficulty.
Ma'am, any difficulty in eating food or what taking?
I'm eating food.
Okay, no problem with drinking water also, no?
Yes, I'm drinking water, doctor.
Okay, ma'am. Ma'am, in this hoarseness of voice, have you noticed that there is any change in the pattern? Like, is it more in the morning or is it more in the night?
No, doctor, it is hoarse 24/7.
Ma'am, along with this hoarseness of voice, are you having any cough?
No, doctor.
Any sneezing or any feeling of nasal congestion?
No, doctor.
Okay, ma'am, along with this hoarseness of voice, do you have any throat pain also?
No, doctor, I don't have throat pain, doctor. I'm having some discomfort in the throat. It's not a pain or anything like that. I'm having some discomfort in the throat.
Okay, ma'am. Ma'am, do you feel this throat discomfort increases when you lie down?
No, doctor.
Okay, ma'am. Ma'am, along with this throat discomfort, do you have any chest discomfort or chest pain?
No, doctor.
Ma'am, any cough?
No, doctor.
Okay, ma'am. Ma'am, another few things I would be asking you regarding the same condition. Ma'am, any complaints of any headache?
No.
Any vision complaints or any mood disturbance?
No, doctor. My mood is just terrible because of this, doctor. My husband is mocking me continuously. I'm disturbed.
Oh, ma'am, I'm sorry to hear that. We'll try to as possible.
Yes.
Ma'am, sorry.
Yes, doctor. Go ahead.
Ma'am, any hair loss?
No, doctor.
Do you feel someone has told you that you appear paler than before?
No.
Any weakness of face or hands and legs?
I feel just generally tired and weak, doctor. It's not something in particular part, but I feel tired and I feel weak.
Okay, ma'am. Ma'am, this tiredness also, are you feeling since the last 10 days or has it been more than that?
Feeling tired for a month. I mean, maybe more than that. I've been feeling tired, I would say. Yeah, not just a month, more than that.
And ma'am, this throat discomfort also, do you feel it's been for 10 days or is it more than that?
Throat discomfort is for 10 days.
Okay, ma'am. Ma'am, along with this tiredness, do you feel any pain in your hands and legs or back?
No, doctor.
Okay, ma'am. Any weakness also? Do you feel like difficulty in walking, climbing stairs, getting up?
No, doctor. I can walk, I can climb stairs too.
Any vision complaints, ma'am? Any eye pain, redness, difficulty in seeing?
No, no, doctor. No.
Any problem with any hearing or balance?
No, doctor.
Any complaints of any throwing up or feeling sick?
No, doctor.
Any skin changes have you noticed?
No changes in my skin, doctor.
Any oral ulcers? Any mouth sores?
No.
Any feeling uncomfortable with any hot or cold weather?
No, doctor.
Any lumps or bumps in your body?
No.
Ma'am, have you ever noticed that you're feeling more breathless?
Breathless? No, doctor. I'm not feeling breathless.
Okay, ma'am. Ma'am, any racing or pacing of your heart?
Sometimes my heart races.
Sometimes, ma'am. When was the last time have you noticed it?
At times, doctor. It's not just like last time. My heart races at times, on and off.
Okay, ma'am. And ma'am, is it with doing any activity or is it at rest?
Both ways, doctor.
Okay, ma'am. And it settles by itself?
Kind of sometimes, yeah.
Ma'am, any weight changes have you noticed?
I don't know, doctor. I felt like, I feel like I'm not putting on weight.
Okay, ma'am. But have you lost also any weight?
I don't know, doctor. I didn't check, but like, I'm not putting up weight, doctor.
How's your appetite, ma'am?
Appetite is kind of okay, but kind of declining these days.
Any abdominal pain or discomfort?
No, not at all, doctor.
Any, ma'am, nausea or vomiting?
No nausea or vomiting.
Ma'am, how's your bowel movements?
It's fine, doctor.
And ma'am, how's your urine? Is it good?
Urine is good, doctor.
Any, ma'am, joint pain, joint swelling?
No.
Any change? Any feeling of fever complaints?
What, doctor?
Do you feel increased body temperature?
No.
Any tingling sensation or pain in your legs or hands?
No, doctor. No.
Ma'am, how's your sleep?
Sleep is good now.
Ma'am, for this hoarseness of voice, have you taken any medicines?
Doctor, I went to see my GP. He just told me to take warm water.
Okay, ma'am, are you taking any regular medicines?
Now I don't take, doctor.
Ma'am, what medicines were you taking?
Doctor, I was taking carbimazole.
Carbimazole. Ma'am, why were you taking that?
Because I had some, they said my thyroid gland is enlarged and my thyroid gland, this could be enlarged and increase secreting thyroid hormone gland, or other doctor doubted whether this can be some cancer growth in thyroid.
Okay, ma'am. So besides carbimazole, were you given any other medicines?
I was not given any medicine, doctor.
Any other treatment, any surgery or any light therapy, anything was done?
Yes, doctor. They took off my thyroid gland.
When was that, ma'am?
A month back.
A month back. Okay, ma'am. And ma'am, along with this, are you taking any other medicines?
Doctor, now I'm just taking this L-troxin as supplement.
Okay, ma'am. Ma'am, what about any allergies? Do you have any food or drug allergy?
No, doctor.
Any herbal medications or over-the-counter drugs have you taken?
No, doctor.
Ma'am, I will be asking some personal questions. Is it okay?
Yes.
Ma'am, are you married or do you have any partner?
Yes, doctor. I'm married. I have a husband. Just now I told you I have an husband.
Ma'am, besides our husband, any other casual partners do you have?
Oh my God, no, doctor.
Any smoking or alcohol intake? Do you take?
Yes, doctor, I do smoke, but I just, I just smoke hookah.
Hookah, ma'am. And are you smoking daily?
Yes, doctor, that is the only thing. I have a hookah apparatus and I smoke hookah, all flavors. Doctor, 8 minutes over.
I would advise you to stop smoking as you already have this above complaints. It will be good for your health.
Okay, doctor, I will try to stop.
Ma'am, do you take alcohol?
Yes, I take alcohol, doctor.
Okay, ma'am. How much do you take?
I just take only 2 glasses of vodka every day, 2 small glasses.
2 small glasses. Ma'am, do you feel that if you don't take, do you feel very agitated or you can't do work?
No, doctor, because I'm taking.
Okay, ma'am. Ma'am, I would advise you to, as you're taking a lot of alcohol also beyond the healthy limit, please kindly reduce the amount.
Okay, doctor.
Ma'am, how's your periods?
Okay, doctor.
Ma'am, and do you work?
Yes.
Ma'am, what work do you do?
Doctor, I'm working as a receptionist.
Okay, ma'am. Ma'am, and there is no issues with your day-to-day activities like driving, right?
No.
Okay. Any family history is there? Anyone in the family had any thyroid problems?
No, doctor.
Okay, ma'am. Sir, I would like to examine you.
Okay, doctor.
Would like to see the neck first.
This is the neck.
Okay.
This is the neck. So similar patient was there in the center. Okay, I just took a picture like that. Only thing the skin was little bit dark. Tell me.
I would like to examine the neck for any lymph nodes.
Lymph nodes. There are no lymph nodes.
Okay. Any thyroid mass and any if it's there.
How thyroid mass will be there, doctor, when it is taken out?
Okay. Okay. I would also like to examine the oral cavity.
For what, doctor?
As they have said, hoarseness of voice, I would like to check for any posterior pharyngeal wall for any redness.
No redness.
Okay. Because they were racing, I would also like to auscultate the patient.
Auscultate where? Base of lungs or heart or abdomen?
I would like to auscultate the heart, sir.
Auscultate the heart. That will consume 2 minutes. Tachycardia, nothing else. Doctor, you have 1 minute, 30 seconds left. Anything?
Okay, sir. Sir, I would like to see the patient's hands.
See, what do you want to see there?
So, first thing, for any tremors.
Nothing is there, no.
Okay.
You have 30 seconds left. 30.
I like to see for any in the thighs, any muscle weakness, proximal muscle weakness.
There is a mild weakness. Time's up. All right. This is the lady.
No more skin.
Okay. Time's up. Yes. Address the concerns, doctor.
Okay. Hello, Miss Dorothy. Do you have any questions for me?
I have, doctor. A lot of questions. What on earth is happening, doctor? My voice is the only thing I had. I need it for my job. It is not there now. What on earth is happening?
Okay, ma'am. I have a few things which I think is the problem. First thing, what I'm considering is, as you are already had undergone this surgery for thyroid. Sometimes what happens is there can be this nerves which supplies your voice box, so it can get damaged, and that can also cause this problem. Other thing, what can happen is it could be because of your the drugs which you could be because of this drugs which you are on. And thirdly, it is also possible that it could be because of the surgery which was done. We have to check for any risk of any cancer.
Okay. Okay. All right. All right. Okay. So you mean to say that the thyroid butcher, he just cut off my nerves? Pathetic, doctor. Sad.
No, ma'am. Okay, ma'am, it is not like that. It is a common complication which can happen with such kind of surgeries. It's a known complication. And
Oh my God, sir, doctor, permanently it's gone. Permanently my voice is damaged.
Ma'am, I would not like to comment on it unless we first do some tests, confirm it, and also get an opinion of this voice specialist and also this thyroid gland specialist, and then I can tell you for sure. For now, if you say it may be a chance.
Maybe a chance. Okay. So what can be done for this, doctor?
So, ma'am, we have this one. We have what we can do is first, once we confirm this, rule out whether if it's a nerve damage, what we can do is we can involve the speech therapist, which can help you with this voice and how to say things more correctly. Can help you in all this.
Oh my God, doctor, stop. All right. Okay. Can you tell me your positive physical findings?
The positive physical findings, sir. There was a tachycardia with proximal muscle weakness was there, and but I didn't find anything else, sir.
Okay. So what are your differential diagnosis? Why she has hoarseness of voice?
My first differential will be was for this post-surgery recurrent laryngeal nerve injury.
Recurrent laryngeal nerve injury.
Leading to hoarseness of voice. Second, I consider because the patient is on L-troxin, but in case if it's less likely, but probably uncontrolled hypothyroidism, which is quite uncontrolled with the current dose of L-troxin.
Uncontrolled hypothyroidism or hyperthyroidism?
Sir, I would go with hypo.
Hypo?
Yes, sir, because the whole thyroid gland has been removed. So,
anything else?
Sir, because there is a racing and pacing of heart, whether there is a Ortner syndrome possibility, I will keep it down the line.
Ortner syndrome.
That causing a left atrial appendage causing a compression, and that as a possibility, as a lower differential, like third or fourth. And I would one more will be a probable surgery done as could be malignancy, local malignancy.
Local malignancy.
Thyroid malignancy, some residual tissue.
Mm-hmm. So how are you going to investigate it? What are the investigations you're going to do?
Okay, sir, my first differential which I would like to do is get a thyroid function test done in her case.
Okay.
And, thyroid function test done, ultrasound of the neck to rule out any other mass or any lymph nodes which might have been missed on examination, or of any mass. I would also, because there is a racing of it, I would like to prefer an ECG.
Okay.
And because there is a recurrent laryngeal nerve involvement is there. This nerve conduction study, if it might help, I'm suspecting if it might help, and this get ENT involved for scopies.
So what you will do if there is a recurrent laryngeal nerve injury?
If it is a permanent injury, the one thing which we can do is speech therapy, which can help the patient.
And
Sir, and that's it, sir. I don't know these other options.
All right. Fair enough. You've done reasonably well. I just wrote Dr. Thomas' name here mistakenly. All right. So sorry. All right. We'll go here. Clinical communication is good. There is nothing I will come. You have improved and you are improving. I'm happy about that. Couple of things. Did you ask about any pills to postpone pregnancy?
I'm sorry, sir.
You asked about oral contraceptive pills?
No, sir. I left it because of the timing.
Well, did you ask about pregnancy?
Same, sir. I left it because of the timing.
Very important. But though not directly related to this case. We'll come to that. Okay. Physical examination borderline. You have to do the thyroid sequence, not auscultating heart and inventing some Wartner syndrome. Absolutely not. All right, I'll tell you. So the same thing, physical examination of the thyroid gland. You are talking about proximal weakness and tachycardia. What is the most important thing? See this video.
Normal skin is supple and mobile over the structures underneath it. After surgery, when we create a scar, the scar can become tight.
What you saw? Alexander.
There is a scar over there.
If you don't tell about the scar straight away, this is gone. That's the most important thing. Thyroid examination is the most important thing. Not auscultating the heart, that is secondary. Auscultating over the thyroid gland, any new tissue regrowth is there, any buoy is there, anything else is there, or any enlarged carotid artery is going and compressing there. All these things you have to first rule out before you go and auscultate the heart.
Okay.
Very clearly. All right, coming to differential diagnosis. Again, this will be borderline. I'll tell you what are the DDs. Clinical judgment is fair enough here. Your concerns are fair enough. Your welfare is fair enough. So what would be the probable differential diagnosis here? So first, okay, there is a recurrent laryngeal nerve injury. Yes, it can. I don't deny that. Next, what are all things that can occur? If the thyroid gland is removed due to malignancy, there can be recurrence. There will be recurrence. New onset malignancy, recurrence can be there. 2, 3. Okay, recurrence. Or not the recurrence, there can be already existing thyroid gland malignancy that could have infiltrated into the local cords. Infiltration. All right. Number 4, post-surgery, sometimes recovery itself will take time. Can consider that. Then, like another candidate type, the carbimazole or anything can cause sore throat, can cause inflammation and cause hoarseness of voice. But there should be other things that is something down the line you can definitely keep. All right. So most common thing, a malignancy, all right, recurrence, infiltration, recurrent laryngeal nerve injury. These are the things. The question went about what are the nerve supply of thyroid gland. None of the candidates knew that. They were like telling only recurrent laryngeal nerve, superior laryngeal nerve, external, even neither I knew. All right, that's how the question went on. And then they had asked, what are the complications of removal of a thyroid gland? So starting from hypothyroidism, everything you have to tell, because I think last week we had discussed the same thing in last week pre-session, right? We had discussed about the thyroid gland thyroidectomy related complication, right? The last week case was a patient with thyroidectomy. Okay, after thyroidectomy, what happened is the patient came with complaints of palpitation. So we had discussed about that last week. So again, another thyroid case has come. So we should be knowing all the surgical complication also, because it's a case that kept. It's not something I wanted to discuss because it is looking fancy. So what are all the things can occur post thyroidectomy? Here I will write post thyroidectomy. All right. First, immediately early can be bleeding or a hematoma formation. Next, residual hypothyroidism. I'm just putting T for thyroidism. Then laryngeal nerve injury. Then hypoparathyroidism. This can lead to hypocalcemia. Then tracheal injury. Then post hypoparathyroidism, post thyroidectomy, There can be thyroid storm also. I even told what are the risk factors for that. Okay, then there can be infection. So what can happen in the late phase? Lot of things. Decreased thyroid, decreased parathyroid, again lead to decreased, calcium, recurrence, malignancy, thyroid storm in some patients, and lot of surgical things. Surgical emphysema can be there. All right, malignancy, then again keloid formation on the scar. The list is huge. Okay, and the list is just huge. Lot of things can happen. So you should be having some fair enough idea of what can happen post thyroidectomy when just you're seeing the patient's scar in the video. And if you don't mention the scar, then gone. They will not be happy about it. That's the first thing, first finding, and examine the thyroid gland. All right. And any doubts, anything, just let us know. No doubts. I'll just close the session now. It's already 9:40. And thank you so much, everyone, for tuning into a free session. All right. And again, tomorrow we have a free session. Dr. Deepak is going to take on abdomen station, how to approach, and also some communication scenarios will be discussed. I'm not sure about my free session. I'll just let you know the availability. All right. And voice treatment, I'll post in the group what has to be done, because I just asked a proper surgeon what has to be done. So let him tell. Okay, I'm just waiting for him. Thank you, sir. You're most welcome. Thank you, everyone, for being here. Timings we will post in the group, Dr. Sipes. All right. Will it get uploaded in the YouTube? Yeah. Free sessions we will upload in the YouTube. No. All right. Because every time we are giving different cases. We have plenty of case collections and patient videos with signs. That's what we believe in showing you all. All right. Okay. Thank you so much, everyone, for tuning in. Please go to our YouTube channel. You can like, share, and you can be a part of, our Patients Diaries, and you can be a part of our WhatsApp group. We are more than happy to help you in every way possible in your patients journey. All right. Thank you so much. And I will see you all again tomorrow, probably. Or if not me, Dr. Deepak will be doing a session at 9 o'clock as usual. Okay. Links, everything. The link, WhatsApp group link, everything is here, doctor. This is the link. You can just click and you can join there. That's the link of the YouTube channel that has all the videos and our podcast. Okay. Thank you. Thank you so much. Thank you, everyone. Bye-bye. Good night.